Welcome to How Else Will We Know with Caroline Fleur. I interview people who have a connection to food allergies, plus other interesting topics as well. Let me tell you what happened to me back in 1951 during my... This show is meant for fun and to inspire thinking and curiosity. We are not giving legal or medical advice of any kind. Thanks for joining. You don't know what's going to happen. I was listening to a podcast called The Picky Bookworm on Spotify a while back, and she was interviewing an author and genetics counselor named Janice Berliner. And I want to say your last name right. Berliner?
Berliner.
Berliner. Okay.
Like you live in Berlin.
Okay, perfect.
Yeah.
Yes. Okay. So Janice Berliner, and this is our first time to talk. And while I was listening, it was interesting, but I had my own questions I realized that I needed to ask. And luckily, Janice agreed to come on and have an interview for my first ever guest. Thank you so much for being here, Janice.
Thank you for having me. It's a pleasure.
Janice was a clinical counselor for 29 years, a clinical genetics counselor. And now she is the director of the Master of Science Genetic Counseling Program at Bay Path University in Massachusetts. That's correct?
That is correct.
That's correct. That sounds like an awesome job. Do you love it?
I do love it. It's overwhelming, honestly. It was a gigantic learning curve when I started there. I will admit to you that being a program director is something I'd wanted to do my entire career. Mm-hmm. So, 28 or whatever years ago, 30 years ago, when I left my first clinical position, which I only left because I was getting married and moving, but I wasn't moving that far. The very day I submitted my resignation was the day they said they were starting a genetic counseling training program. And I went home and cried because had I known they were starting the program, I would have stayed. And that's the only reason I know that my entire career, this is something I've been wanting to do. And for a variety of reasons, mostly geographic, I wasn't really able to make it happen until a little over 3 years ago when I started this job at Bay Path. And despite the fact that I live in New Jersey and the job is in Western Massachusetts, because it's a virtual program, I can do it remotely.
Yeah, and that's wonderful.
Yeah.
I mean, I thought it was so interesting. And so you had the first chunk of your career was the genetics counselor. What does a genetics counselor do exactly? Share that with us.
Yeah, I've heard that question about 9 million times throughout my career. Even when I was in grad school, people say, "You want to be a what?" And I think the profession of genetic counseling has hit its stride in years more recent than when I was in school. So that now when I say I'm a genetic counselor, people say, "Oh, I went to one of those." So there are a few different sort of bread and butter areas for genetic counselors to practice in. One is prenatal or even preconceptional. So for people who are thinking about a pregnancy or have already conceived a pregnancy where there are concerns that there may be a problem, either based on family history or the mother's age or exposures that she's had to medications or drugs or alcohol or chemicals in the workplace or anything. Sometimes there are screening tools that have questionable results and you need to follow up on those. There may be something wrong. So there's a lot of discussion about genetic testing and ultrasound and what can be detected and when, and what do you do with the results once you have it. Another very large area of genetic counseling is in the realm of cancer risk assessment. Okay. So that's talking to patients, I should say people who either are cancer patients or are family members of them, where there's some expectation that there may be something hereditary about this cancer. And I will say 90 to 95% of cancers are actually not hereditary, contrary to popular belief.
That's interesting.
But for those that are or might be, there is actually genetic testing we can do. And, every year it gets more extensive and we can do more than we used to. And at the beginning of my career, there was no field of of cancer genetics.
Right.
It didn't exist because we didn't know enough. We knew enough to know there was something hereditary about some cancers, but that's all we knew. Now we know a lot. So we can actually, at this point, offer very large panels of genetic tests to, in essence, throw everything at the wall and see what sticks. It's not really everything, but it's getting there. And then there are plenty of genetic counselors who operate in pediatrics settings. So you may have a child or a young adult who has something going on that seems sort of out of the realm of what you might expect for an average child, and yet you don't necessarily know what's wrong. And sometimes you do know what's wrong, but you need to follow those children over years. So, for a lot of those cases, the issue is treatment and care of this child, but it also may be recurrence risks. The parents may say, if I have another child, what's the chance that this could happen again? So that's where genetic testing there's so many ways it can be really handy. Diagnosis for one, which helps with treatment and prognosis and so forth, but also for family planning and management of family. So there's a whole lot of other things. There are, cardiac genetics and ocular genetics and psychiatric genetics and neurogenetics. It's now expanded into so many different things, but that's kind of the mainstay of what we do and how we do it.
Yeah, and that's so true because, since my son has food allergies, we only have one child, but it would make sense when you have a condition, so somehow it happened. If you were going to have another child, you would want to know, is this going to happen again if the technology is there? So right. I think that's interesting. So after I heard the podcast with you, I went and looked up genetic testing for food allergies. I'd never thought of it before, but maybe because we only had one child. But from what I've seen, we're not there yet. It's not happening yet. There's still research happening, though, that will lead up to it, which is exciting. So we're still in the research phase, I think. But I came across an article, a short summary really on snacksafely.com, something I follow. And their CEO, Dave Bloom, did a summary over a study that had interesting results. And just a side note, he calls himself the blogger in chief, which I thought was funny. But and basically there's this gene that's the EMSY gene that's already been connected to eczema and asthma. And that was interesting to me because eczema can be a sign of food allergies. And a lot of people with food allergies have asthma. So it just makes sense. So I went and I looked up the study itself and I read it. And it was very intricate. A lot of it went over my head. Just so I can make sure I name it correctly. The study was in the Journal of Allergy and Clinical Immunology in March of 2018. I'll attach a link to that as well. But it was a real study, but progress is being made. And I think that's what's exciting because there's just so many people with food allergies. I already knew that 1 in 13 children have food allergies, which is high, but new data just came out that said 1 in 10 adults now has turned allergic to a food. So it's an epidemic. And in that thinking, I wondered, is anyone coming in looking for genetic testing for food allergies yet? Are they asking?
Yeah. Not being in clinical practice anymore and having been working in cancer centers for 20 years, it's really hard for me to say, is anybody doing that? I will say that there are an awful lot of direct-to-consumer genetic tests that are out there now. And some of them do say that they test for propensity toward food allergies. Just like some will say, we test for likelihood of one day becoming diabetic. They're not testing you to see if you are diabetic. That's done through blood glucose, right? It's not a genetic test. And they test you for, whether you may have Alzheimer's one day and whether you are at higher risk for cardiac disease. And then some of it is just sort of more performance stuff like, will your child be a better sprinter or long distance runner? So you know what sport to put him in.
That is important.
Yeah. Oh, yeah. And so the problem with a lot of these tests, and I will start by saying, I think they have a tremendous amount of promise. I do think that one day these direct to consumer tests for a host of different things are going to be accurate and helpful and have their uses. Right. But at the same time, I want to kind of caution anybody who's listening to this that a lot of these tests are not necessarily ready for prime time. So a lot of genetic testing or these kinds of things are done using what are called SNPs, single nucleotide polymorphisms. It's kind of like saying, well, it's complicated to explain, and I'm not the best one to try to explain it. But the basic thing is that we're not doing full gene sequencing of everybody's entire genome to see what's right and what's wrong and what could be better and what are normal variations versus things that could potentially be harmful. What we're doing is looking at little spots in different places that may or may not be sort of different from the norm. And so depending upon the combination of SNPs that you use, your results may be different. So one test may tell you that you're at high risk for hypertension, and another one's going to tell you that you're not. Or pick one that might even be more serious. One's going to tell you you're at high risk for lung cancer and another one is not. Well, if the one tells you, oh, you're at low risk for lung cancer, are you then going to go out and say, well, then I could just smoke with impunity?
Let's smoke it up.
That seems like a really bad idea, even if not for you, but for the people around you.
Right.
A lot of the common conditions that we think of as maybe being hereditary, whether it's diabetes or high blood pressure or food allergies or cholesterol, whatever it is, these are multifactorial conditions. They generally speaking require some underlying genetic predisposition, on top of which you need who knows how many environmental and other factors. Other factors could be different genes that may impact on these genes. There's so much that we don't know. So, can you smoke for 40 years, 4 packs a day and never have lung cancer? Sure. Can you develop lung cancer if you've never smoked? Yes.
Yes, too.
So yes, too. So does cigarette smoking cause lung cancer? Well, yeah, but not by itself. And not always.
True. That's
so
true.
We know there are a lot of different things that go into most of these, especially adult onset conditions. So that's one, I think, really important thing to remember. The other thing to remember is that not everything that's hereditary is strictly hereditary, and not everything that's hereditary is going to affect everyone in the family. So I can't tell you how many people have said to me, not patients, usually family members, friends will say, yeah, but it's in the family, so like we all have it.
Yeah.
No, it doesn't work that way. You have to know what the pattern of inheritance is, and then you know who's at risk, but then not everybody's going to be affected by it either because they didn't inherit it to begin with, or because they didn't have whatever those other factors are to cause it to be expressed, right? So it's very, very nuanced. It's not generally speaking, a black and white thing.
That makes sense because, well, it makes sense also, like you said, a lot of times patients that you see, they have their ideas, because I've said some things like, well, we don't have anyone in our family with food allergies, but my husband has asthma and I have environmental allergies, which I'm having right now. So maybe the combination of the two, we don't know. We just make up our own.
No, we don't know. And right. And so many people I find, and it's perfectly natural. I'm not trying to say, what a silly thing. It's real.
It could be.
It could be, but we go by our own experiences, right? So when people, for example, will say, oh, you know what, twins, they skip a generation. I know that because my grandmother was a twin. And
everyone says that.
They do. It's not true. Nothing skips a generation. Nothing. Because you cannot pass on what you don't have.
Oh.
Okay. So if your mother had something and your child has it, you do too. You just don't know it. Why don't you know it? Well, it may not be expressed clinically, but you cannot pass on what you don't have. It doesn't float through the air from your mother to your child.
Oh,
okay.
That makes sense. And
it does. And I've said this to hundreds of patients over the years, and everyone has done what you do. That makes sense. But you never think about it because that's just what people say. Yeah. I don't mean but your anecdotal observations don't equal science, right? And so we could say that about a lot of things right now. Yeah. But anyway, there are many different, what's the word I'm looking for? Principles, I guess, in genetics. One is reduced penetrance. Penetrance is a measure of the percentage of people who have a gene for something who actually express it clinically.
Okay.
So to say that something is 75% penetrant means 75% of the people who have a genetic predisposition for X will actually develop it in any way that would be diagnosable or noticeable.
Okay.
There's another principle of variable expressivity. So, one person can have a disorder in such a mild way that it's really kind of never brought to medical attention.
Okay.
Until and unless someone else in the family is. So you may have a parent who has, for example, neurofibromatosis, who never knows it, just knows he has some like freckling and some interesting little things. And then a child is born, child has at whatever age, a much more serious condition. It comes to the pediatrician or to the pediatric geneticist or the neurologist or whomever. And, the doctor says, this is a dominant condition. One of you probably has it. And you do a real careful exam. And you go, oh, look at that. Dad has it. Never knew it.
Right. So this must be why you get these small things. They put it together after.
Exactly. And also there are things called new mutations. So for example, my daughter has celiac disease. Nobody else in the family does. She kind of came out of nowhere, but it is a dominant condition. So if she ever has biological children, which she's not planning to do, but that's a whole other story, each of her children would be at 50% risk to have celiac.
Okay.
Right. So it's easy to say, well, it's nowhere in the family. Well, sometimes they come out of nowhere.
Somewhere. Yeah.
That's right. And a lot of conditions, and I know I'm getting way ahead of us probably, but it's what I do.
We're learning.
Right. A lot of conditions are inherited in a recessive way. It means that each parent has to be a carrier and each parent has to pass that gene on in that pregnancy. So we all have 2 copies of every gene, one from mom, one from dad. If you have one copy that is, I hate to use the word, but normal or typical or average, and then the other one, if the person has 2 copies and one is, normal and the other is not,
right,
then when that person goes to have children, he or she perfectly healthy doesn't express this condition because you need to have both copies in order to be affected. But that person's a carrier. If that person passes it on in a pregnancy, that's no problem as long as the other parent doesn't.
Right.
But if the other parent happens also to be a carrier of that same condition, and they both pass it on in the same pregnancy, then the child doesn't have any, quote, normal copies, and that disorder, disease, condition, whatever, will be expressed. So for things like Tay-Sachs, cystic fibrosis, sickle cell disease, a lot of conditions that are recessive, people will say, oh, it's not my family anywhere. Well, I wouldn't expect it to be, because the only time you'll see it is if 2 carriers have a child together and both pass it on.
I guess for people not in the field, we try to really simplify it where we can understand it. And it just shows how complicated it really is.
And that is exactly why the field of genetic counseling was born, right? The whole point of a genetic counselor is to empathically, compassionately, and in clear terms, translate all this very complicated information for the layperson who doesn't and has no reason to understand all of this, right? The whole idea is it's very complicated. Let me explain to you what this means, how this might affect you, what genetic testing may be available, and what the benefits, risks, and limitations of that testing is. And then, of course, the very obvious, what do I do with that information once I have it?
What can we do now?
That's really the bottom line. What can I do? And how do I process this? How do I think about the fact, for example, that I passed on a gene to my child that made him sick, even if that child is 50, right?
Of course. You don't want to do that.
It's a very, very tough thing for a lot of people to handle, even when you say to them, do you blame your parent for passing it to you? No, of course not. He never could have known that he did that. Right. Why would your child blame you?
Right. So you do see kind of a sense of guilt sometimes in people that carry the gene, even though there's no way they could have known.
Yep. There's nothing they could have done to cause the problem or to prevent the problem.
No.
And so, should they feel guilty? Use that word. No, but you know what? We all take responsibility for our children. I've had 20 years worth of migraines, and every time one of my kids has a headache, I'm so
Like,
sorry.
this
What
is
did I
all
do? I
my
didn't do it. It
fault.
wasn't my fault, right? I don't blame my mother for passing it to me. Why?
No.
But why do I feel guilty? Because that's what parents do. Does my mother feel badly that she passed it to me? You bet she does.
Why do we do that to ourselves?
I don't know.
What is wrong with us?
I
But
don't
I
know.
if someone had taken me aside and said, your husband has asthma and you have environmental allergies and you have a high chance for a child with food allergies, I think we would have said okay and had a child. I don't think we would have said
that. Right.
Really? Well, forget it now.
Yeah.
We wanted a baby. So it does ask the question, what can you do about it? I mean, it's good to know the knowledge. And then sometimes you can do something.
That's
right. Sometimes the technology is there where you can do something.
Well, exactly. So I can, if you're interested, I can give you a few examples of that.
Mm-hmm.
So one, if you find out prenatally that the baby you're carrying has spina bifida, which is a condition where a part of the neural tube is open and the spinal cord and nerves are exposed to the air, mm-hmm. or in this case, the amniotic fluid. That's a very, very harmful, or can be very, very harmful condition, depending upon where the lesion is and whether it's related to anything else. But if we know that before the baby's born, then we can do a C-section and not have the baby go through the birth canal where that opening can be infected. That's huge information.
That's huge. And so
right.
I'm the parent of a teenager, and I can tell you, he was on the beginning end of this whole food allergy thing. It took years to figure out what was wrong with him. And we even went to a pediatric allergist who told me he couldn't be allergic to all these things or he wouldn't function. And it was another couple of years before a different doctor said, he's not functioning, he's sick.
That's the problem. Yeah.
And so it was, just trying to find out what was wrong with him, because food allergies changed. It wasn't only anaphylactic and rashes anymore. It was coming out in other ways. They were sick and they didn't know it because they're kids and they can't say, hey, I feel terrible. They just thought, this is my life. And he was throwing up all the time. I mean, we knew something was wrong. I was even told, let's just wait and see. I was like, are you out of your mind? My child's sick. But they didn't know. So yes, just if someone had said, you are at risk to have a child with food allergies, well, as soon as he got eczema as a baby, I would have said, ding, ding, ding. But back then I got lotion from the doctor.
Yeah.
So I'm like, they didn't know. It was nobody's fault. It was new. And we happened to be on the beginning of it instead of the end. Now, if you have the symptoms my child had, they're on it. They know. Yeah. So it shows what research and testing and everything can do. It's huge.
The amount of changes that have happened in genetics in my 30-ish year career is astounding to me. Truly. You can't even put into words the amount of growth in the field and what we can do now versus what we could do then.
I mean, it's exciting.
It is.
I think it's exciting. For me,
it is. And there's a whole
cure could come. I mean,
well, right. And there's a whole world now of personalized medicine, pharmacogenomics, and so forth. So now, for example, we can test tumor tissue from somebody who has a cancer and figure out, not always, but sometimes, what medications are going to work the best for that. So, I mean, you never want to put somebody on a toxic chemotherapy regimen if it isn't going to work, not only because it's toxic and it puts the person through so much, but also because you lose all that time from not putting them on a drug that actually does work.
That was the one that would help.
Exactly.
Yeah. So maybe
have so much more. Is it foolproof? No. Can we cure every cancer? No. But we can cure a lot of cancers. So people say, if only we had a cure for this deadly disease. First of all, it's not one disease, it's many, many, many diseases. But besides that, we do have some cures. And there are millions of cancer survivors who are cured.
They're cured. That's really exciting.
So,
one thing I wanted to ask was, when a couple comes in, like in your book, they went for genetic testing. And when someone goes in for genetic testing, for whatever reason, do they all have the same process, or is it tailored to them? What happens?
Yeah, a lot depends on the setting where you are, right? Okay. So are you going to a doctor? Are you going to a nurse? Are you going to a genetic counselor in a academic medical center where they have all sorts of of things and a lot more knowledge. So that's one thing. Another is, what is the reason that's bringing you in? So if you come in as a pregnant couple for carrier screening, because you want to know, what on earth could you potentially be at risk for having a child with, that's terrible grammar.
We get it.
Then there's not a whole lot of counseling involved, right? It's let's test both of you. And if we come upon something that you both carry and therefore is an issue, or only one of you carries, but it's a dominant condition and only one of you needs to carry it, then we'll sit down and talk about it in a lot more detail. So the process is, fairly minimal on the front end. And if there's anything to discuss, it'll be more detailed on the back end. When you're seeing a genetic counselor in a cancer center, for example, there's a very lengthy pre-test conversation that has to do with first gathering family history, usually a 3-generation pedigree at least, maybe more if you find things that you want to explore down one particular branch of the family, to try to figure out what, if anything, looks like it might be going on from a hereditary standpoint in this family. And then you can tailor your testing based on what you think you're seeing.
Okay.
Now, in the last 5 to 10 years, closer to 10, now that we have what's called panel testing, that was enabled by something called next generation sequencing, where we can do a lot of genetic tests all at one time. Now there are a lot of cancer centers where they're saying, well, again, let's throw everything at the wall and see what sticks. So instead of testing somebody for, there's a family history of breast cancer, let's just test them for breast cancer genes. It's let's test them for an 84 gene panel because we can. And then, we'll deal with it on the other side. And there are pluses and minuses to that I don't need to get into now. But all of that is the stuff that counseling is made of. Is what kind of testing might we order for you? What will it tell us? What won't it tell us? And what will we do with the information once we had it?
Okay.
Which is a long way of saying the process. Realm. Yep. And the process is very different depending upon where you go and who you see.
Okay.
And what type of professional you're seeing. Yeah.
Okay. That makes sense. Again, intricate, complicated, moving parts the whole time. I mean, I want to bring up your book now, and I read it on Kindle. So what I did is I pulled up my iPad because I wanted to show it. Show Books Promise. That's the beautiful title. I really enjoyed it. And I learned a lot about genetic counseling in the book, which was interesting. And it revolves around infertility, which was great. And it made me wonder, since parents come in and they're nervous, and of course they want good news, right? They're hoping for good news. And obviously, sometimes that's not the case. So how do you address bad news with parents when that's such a touchy, deep, painful subject? And just how do you address that?
Yeah, it's not easy, of course. I don't really think there's anybody who goes into any area of healthcare who doesn't have compassion for the patients that they're seeing. At least I would hope not.
Right.
And it is very difficult to tell parents that their child is going to have, or already does have.
Has it.
Has it already. Yeah. It's very, very tough. What I found, haven't done this in many years, is that people tend to appreciate being told right away, and then you can explain. So, particularly when they came in for testing and they've been waiting for weeks for the results, they come in on pins and needles and they need to know immediately. You can fill in all the information later, but if you start with, okay, so we did this testing and this is what we tested for, like just spit it out and then clean it up.
That's a good point, because they're dying to hear.
They are. And they're not hearing you anyway, because all they want to know is yes or no. And they're starting to wonder, why would you be building up to all of this if you're just going to say everything
if it's not terrible? Yeah,
exactly.
That's true. I didn't think of that, because it can't be good if they didn't say everything's fine.
Exactly. Right. So it's just tell me already so I know what it is I'm dealing with.
Right.
Now, of course, a certain amount of groundwork is very important, because if you just throw out a term and say, your child has alpha-1 antitrypsin deficiency, parents are going to say, What?
What?
Right. So that's where a lot of the pre-test counseling comes in is, these are the features that your child has, and this is the differential diagnosis, right? These are the kind of the 4 or 5 things that we think might be going on based on these features. So let's test for these 2 because they're the most likely. And if those are both negative, then we can test for the rest. So if all of that is explained ahead of time, it makes it a lot easier to start out by saying, remember we said we were going to test for these 2 things first. Well, we did find a mutation in the gene for alpha-1 antitrypsin deficiency. And then you stop. And you say, let me let that sink in for you. Do you have any questions before I continue? Give them another little chunk. I used to think of it as taking a bite, chewing it and swallowing it before taking another bite. Because if you give it all to them to eat at once, they will choke.
They will choke
and
throw up.
Yes.
Because it's just too much. It's like
it's too much. It's too scary. It bubbles up so many questions at once. They don't even know where to start. And in the meantime, all they want to do is love their child, and they will, and they should, and they can, but it's a lot. And it's the same kind of thing when you tell somebody that, the cancer that you have, it actually is hereditary. Here's the mutation. Right. And we now call it pathogenic variant rather than mutation, but
right.
Same kind of thing. And so now, is that good news or bad news? Well, it's bad news in the sense that now we know your family members are at much higher risk to have the same thing. But it's good news in the sense that we know how to test them. Yeah. So we might actually be able to protect them. Yeah. They will have information that you didn't have. So it's a very delicate balance, and how people interpret it is very personal. And a lot of it is based on their past experience. If you have a strong family history of breast cancer, and everybody in your family who had it passed away young and had terrible surgery experiences and died painful deaths, then your idea of what it is to be diagnosed with breast cancer is very different from somebody who comes from a family where, a few people had it, but they did really well. They had mastectomies or lumpectomies, they had radiation, and they're here to talk about it 30 years later. So they might say, well, yeah, that would suck. And like, who wants to have breast cancer? But it doesn't feel like a death sentence. It's not the same thing. So taking that into account, that's another really important reason to take a family history. It's not just to assess risk. It's also to kind of figure out context.
Right. That makes sense. Yeah. And just what you're saying about having the knowledge beforehand has to be less scary, because you think, okay, well, here's all this that it could be. We don't know. We're going to go find out, instead of learning it all at the same time.
Right.
Like, here's what it is, and here's all that means.
The only downside to that is the old Dr. Google, right? Because if you find out these are the several things it could be, and then you go and research in the 3 weeks that you're waiting for the test results, and you come in thinking that things are potentially far more horrible than they might be. Not only, if you go to good sites, the Mayo Clinic, the Cleveland Clinic, the American Cancer Society, then you're fine, generally. But if you go to blogs, and I don't mean that people are intentionally misleading. Some might be, but the majority are probably just talking about their own experiences.
Their personal
and people love to moan about bad things. They don't necessarily tell you the good things. And so you can be led down such a rabbit hole of horrendously terrifying things that will likely never apply to you, right?
Right. That's true.
Yeah.
There's also not only Google, which has terrified me many times in the middle of the night.
Me too.
I've learned not to work on my PhD in Google. I just try to keep it very factual.
Very smart.
But the other bad thing is sharing your concerns with well-meaning friends who will then build on it by saying, oh, I knew someone who had this.
Exactly.
Right. Oh, no, that's not what I wanted. I wanted to hear, I'm sure it's fine.
Well, and sometimes they create a very strong social network for you, right? So if you were to tell somebody you had a miscarriage, likely you would hear, so did I, or, oh, my sister-in-law did, or my best friend did. And, you can build a support network from that, because there are things that people don't tend to talk about unless there's kind of safety in numbers. But it is true that then you hear all the horror stories.
Well, if you've ever had a child, what did people tell you when you were pregnant? Let me tell you what happened to me back in 1951 during my... It's like, no, please don't.
It's so true.
And can everyone stop asking me if I'm having twins? That is not helping the
No.
situation.
You know what always bothered me is, do you know what you're having? I'm like, it's a kumquat. It's a baby. What do you mean, do I know what I'm having? Do you mean, do I know if it's a boy or girl? No, I do not. Right.
Like, I think it's a baby.
The phraseology of the question, I'm like, it is not a chameleon. I'm guessing it's a human baby.
That's so funny.
I have a lot of pet peeves.
I'm sure you hear it all. So, okay. So back to Brooke's Promise, your book, which I'm going to read the blurb for in a second. But something that happened in the book, and I'm going to be careful because I don't want to give anything away, but something was overlooked by the genetic testing. And it was explained why that happened. But the character was angry about it. And he was looking for, or scared, and just looking for somewhere to put blame for not knowing. And I was just curious if during your counseling time, if anyone ever turned on you as the messenger, because you're giving them this terrible news and maybe you're an idiot and you don't know what you're talking about.
Yeah, I have. I think I've had that, oddly enough, more on the pretest side of things. You know, so if I've said, theoretically, we could do a really large panel of genes, but I think the reason to do just these 6 is, and then you'll have somebody, and I found it was typically the spouse, not the patient herself, who would, and I don't mean typically like it happened a lot, but in the couple of times that it did happen, there was a lot of yelling going on of, why shouldn't we be able to have this testing if we're willing to pay for it and it doesn't have to go through our insurance? We should be, you know, we're the patient. We should have the right. And, you know, it was difficult not to rise to that and start yelling back and say, wait a minute, hold on, we're the professionals. There's a reason we're recommending this. And there's nothing wrong with saying that to some extent, but you have to take a step back and realize exactly what you said. It's coming from fear, from anxiety, and from loss of control, right? Particularly, I find when it's husband and wife. He's always wanted to protect her. And now she's sick. And not only can't he do anything to protect her from the illness, he can't even help with this. And maybe his children are also at risk and he can't protect them either. And that feeling of lack of control is where a lot of that stems from. And so it took me a long time to really piece that together and realize that it's okay. And that there are statements you can make to people to try to help with that. You know, I'm sensing that you're having some anxiety over that. That's totally understandable. Let me explain again why we think this is going to help you. Sometimes it works and sometimes it doesn't. But it's at least an approach that validates what the people are going through.
Yeah, and validates their feelings and names it.
Or names it.
You can name
and
it.
Maybe de-escalates it, you know, where people will say, you know what, you're right. Yeah.
So,
I think so. And for parents regarding their children, same kind of thing. How am I not able to protect my child? That is my singular job in this relationship, is to protect and love this child. And, you know, I can love all I want, but that doesn't protect him from his food allergies.
Right. That's so true. I mean, there were plenty of times where I was like, how could I not put this together? You know, I'm a terrible mother. Why didn't I know? Well, I saw like 24 doctors and they didn't know, but I'm his mother.
That's right.
You know, I should have known.
It's a perfect example. Why does that responsibility fall to you? Doesn't.
It's my DNA.
I feel the same thing. I was 26 years old when my father passed away. And I think about it now. I saw his terribly swollen ankles. Why didn't I know he had congestive heart failure? Well, the man had a cardiologist. It wasn't my job as his daughter to know that he had cardiac, and I wasn't going to do anything about it either. What was I going to do about his congestive heart failure besides nag him, right? But it lingers in me all these years later.
Yeah.
How did I not see that? I mean, I did see it, but how did I not put it together? You know?
Well, that's why some brainiac said, hindsight's 2020. Well, yeah.
You're not wrong.
That's where that came from.
Yeah.
Okay.
Exactly.
Well, that's so helpful. I appreciate knowing all that. So I am going to read the blurb for Brooke's Promise because I want to talk about that because I really, really love this book.
Thank you.
Okay. So first I'll just read it. How do you put your life back together after learning your past is a lie? 30 years after 15-year-old Julia is misunderstood by her parents and sent to boarding school, her son pushes his wife into a pregnancy she isn't wholly ready to undertake. When their beautiful baby girl displays a frightening failure to thrive, a series of medical evaluations led to the diagnosis of a devastating disease that reveals a world of secrets and threatens to unravel their marriage and their families. The tension mounts as two mothers are forced to uncover truths that they don't want to face and discover a past that will have life-altering consequences for them and everyone they love. At the same time, Susie and her daughter relationship, their past, and the ties that do or don't bind them. The intertwining of Susie and Julia's families illuminates more devastating secrets from their past with ultimate healing. Brooke's Promise is a bold and hopeful story about changing expectations, forgiveness, and reconciliation. I love that. And I read it without my glasses. So that was impressive to me. I was like really focusing. So that is the blurb. And I read this book. I really loved it. And it was just really informative, but it didn't feel like the information was being pushed on you. Like, oh, look at me learning. It's just part of the story. And you think, I just saw insight into something I'd never known about. So I can't say what, so everyone should go read it and see. But I had a question. So when I wrote my book, I started to realize what a big task it was. It is a huge undertaking to write a book, even a fiction book like mine. And I asked myself, why do I have to write this book? What will happen if I don't write the book? And my answers were, I have to write it because I want to have a fun story that also includes food allergies, so people can just get a glimpse of what's going on behind the scenes in a family where someone has food allergies. And if I don't write it, so far I haven't seen any books about it, and people won't be aware of what the problem is or what it's really like. And awareness brings money, research, empathy. So there won't be something to help promote that. But it made me wonder about Brooke's Promise, and wondering from you, why did you need to write this book? And what would have happened if you hadn't written it?
It's such a great question. I really appreciate that a lot. It is a very similar kind of story. You know, here I've loved genetics for my whole life, and I find it so compelling, but most people I find are scared of it. They think it's so complicated, they'll never understand it, or maybe they'd rather not understand it. I don't know. But, you know, I've read a number of books by Lisa Genova, who wrote Still Alice and Inside the O'Briens and Every Note Played. And they're wonderful, wonderful books. You know, she has a PhD in neuroscience from Harvard. She's a brilliant woman, but turned novelist, right? So her goal was to bring neurologic conditions to the average reader. And that's how I felt about this, is I want the average person who's just reading for fun to understand what genetics is in whatever, you know, small way. Like you said, just bring some awareness. It doesn't have to be anything really deep, but to normalize conditions that are hereditary, that may, you know, look different or feel different, or put someone in a wheelchair, or cause them to have a very special diet where they can't, you know, eat cupcakes with the rest of the class on somebody's birthday, or whatever it might be. There's so much misinformation and lack of information out there. So if I didn't tell the story, that would continue to be true.
It is true. And I was one of those people that were a little bit afraid of things like genetic testing. Oh my gosh, no. I believe it was mentioned to me. They did something and said if it came back for cystic fibrosis, that was what they were starting to look for when I was pregnant. And I thought, well, I don't want to know that. I mean, that's too scary. And luckily it didn't, but I don't know what I would have done. But I remember being afraid. And I don't feel afraid now that I read the book. I don't feel like it's
wonderful,
scary. It feels like, well, I always want to know more knowledge. And it feels like, even if it's scary, it's good to know. You know, it's good to have some understanding. Maybe what's scary is not understanding.
Right. And I think a big part of the problem, and this is just human nature, is that magical thinking of, if I don't know about it, it won't actually happen. You know, it's, and we could liken that to COVID too, right? It's, you know, let's not recognize how bad this is and maybe it'll go away. Sadly, it doesn't work like that. So, you know, for you not to have, I don't know, an EKG because you don't want to know that you have a heart disease, you have it whether you know it or you don't know it. But if you do know it, you can treat it. right? If you don't know you have diabetes and you don't take insulin, you're going to have a whole lot more problems than just your blood sugar level.
Right.
So
True.
it's, you know, and that's where the expression knowledge is power was born from.
Okay. So with your book, with my book, when I started writing it, I had a different ending in mind. Okay. But when you start writing a book, sometimes the characters take over and they do whatever they want and they go rogue.
So true. It's so true.
So in your book, in Brooke's Promise, I keep saying that because you have another book I'm going to bring out. So when people go looking, they're going to see the other one. So this is still Brooke's Promise. Right. There are two characters that find out why their child had a genetic condition. And there's a point where the reader doesn't know if they are going to stay together. And you don't know what's going to happen. And because of this, I stayed up half the night because I had to get to the part where at least started on the answer, because I didn't know, I couldn't predict what were they going to do, right?
Yeah.
And I really enjoyed that. But it made me wonder if you had thought of a different ending for those two characters, because there were different paths they could take. So I wondered if there was an alternate path that you considered.
I really didn't. I mean, you're absolutely right that characters take over. It is shocking how the book kind of wrote itself. Right. But a good friend of mine who had started a nonfiction, sort of a financial kind of book, had said to me, make an outline of what you think your chapters are going to be. So you figure out how to go from beginning to end, and then put a little bit more meat on the bones of each chapter, and then go back and do more of that. And by the time I did that, it really practically wrote itself. So I had a paragraph this long for each chapter. This is what's going to be in this chapter. And there were times when I kind of, move things around. But I always knew this was my beginning and this was my end. And a little bit was like, how do I get from
there? Yeah. That's the pesky middle part that we can't even go there. The middle.
You know what? I loved it. I loved everything about the process. The only thing I didn't love was a few different rewrites. So for example, you'll remember there's a deposition in there, where one of the main characters is an attorney and she's doing a deposition. And so I originally wrote it as a trial. Okay. And my husband, who's very involved in bankruptcy, but not from the legal side, more from the financial side. But he works with a lot of lawyers. He read it and he said, "You can't do that." Why not? Why? He said, "Because this case would never have made it to trial." I said, "Yeah, I thought of that, but." He's like, "No, but. This would never have made it to trial. And if there are any attorneys who read this, they're going to say that's ridiculous and, dismiss the whole thing." Yeah. Okay. So how do I write a deposition? So we talked that through. You want it to be correct. A little poetic license, but not too much. Right. So I changed the whole thing to a deposition. It took a lot of work, but I was very pleased with how it came out. And he read it again and he said, "It's still wrong." I swear those were his words. "It's still bad." I said, "Why?" What now? He said, "Because you don't have all these people in the room for a deposition. It's one client at a time. They don't do it all together." I said, "Now you tell me that after I reworked 4 chapters? Like, why would you?" Okay. Yep, I thought you knew. Well, all the cases, all the Law and Order episodes. I'm like, oh my God, I never noticed that. How would I know? No, they can be so useful. Back and change it again. You had to do it again. No, that happened to me a couple of times in my book. One of them, we traveled a lot, so I didn't think about it, but I put my main character on a plane. I didn't even think about it. And when my husband read it, he said, "That seat's not where you think it is," because he's traveled a lot for work. He's in IT. And I said, "What do you mean?" He's like, No. You have her getting on the plane and this seat is not where you think it is because of how it's laid out." And I was like, oh, I had to redo it. Well, is the seat here? Am I getting closer? But it's true. You just want poetic license, but as everything to be correct as much as possible, so that someone doesn't write in the comments, "That seat is not there on a plane. Have you ever even been on a plane?" That's right. Had you researched, you would have known. I did the same thing. So the disorder that little Brooke has, I had originally made something else. Okay. It was an homage to my son who doesn't have this disorder, but I was afraid that he did when he was a baby. And he has laughed his head off ever since. Like, how could you think I have this ridiculous thing that has such a silly name to it? And so I was just going to do that as a little secret thing to him. And then as I wrote it, I thought, oh, hold on. This would have been discovered on newborn screening. I can't use
Oh,
that.
so you can't, because that would have.
So then I had to go searching for something that would not be detected with newborn screening and
Yeah.
put it in a state where that was the case, because every state does it differently. So
Of
this is the
course.
only reason that this book is set in Vermont. I have no ties to Vermont particularly,
Okay.
other than a cherished aunt and uncle used to live there. But besides
Yeah.
that,
And Vermont's awesome. So there's
and
that.
Vermont is awesome, no doubt about it. But that's not why it was there. It had strictly to do with newborn screening. But then, as I was doing more research and I had written this whole thing about it, I said, oh my God, now there's enzyme replacement therapy. This child could have been helped. Like, what do I do? I'm not changing it again. And then I said, oh, I know. I'll just set it back 10 years. Then I don't have that problem. So that's why it's set in 2008.
Okay. And what you thought, I'm trying to remember, I think this came up on the podcast, what you thought your son might have was some kind of like chocolate syrup disease or something.
Maple syrup urine disease.
Okay, yeah.
Yes.
Is that what it's called?
I told that story already.
Maple syrup disease?
Maple syrup urine disease. Literally open the baby's diaper and you're like, okay, that smells like maple syrup.
Oh.
And that actually happened when he was a baby a few times. And I have to say, when you know what you know, it's scary. And he's like, Mom, that's ridiculous. I'm like, it's not though. This is a real thing. And if you had it, I needed to know immediately so I could do something about it.
Yeah.
He's like, well, you let me roll off the changing table. All right, whatever.
At least, good. I'm glad he didn't have it. That's why it's ridiculous. Because he didn't.
Right. It would not have been at all ridiculous if it had turned out to be true.
Right.
And there are plenty of children who do have, and adults, who have this disorder. So adults.
And the name seems ridiculous, but then it's also genius because it's so identifiable. It's not confusing, like some name no one's ever heard of.
And it does have a long scientific equivalent name that I just don't remember right now because we've always just called it that. And the genetics community, that's just what we've always called it. Mm-hmm. So it's really funny how some things are called by what they sound like galactosemia, it's a problem with galactose, it's a metabolic product. So, that's called by its name. Then you have something like Wilson disease, which is named for the scientist who described it, and then you have maple syrup urine disease, which is just described by its main identifiable feature. Right. So there's no rhyme or reason to this. And now there are some chromosome deletion syndromes that they're just called 22q. We don't need to give it a name. It's just 22q.
Yeah. I mean, that makes sense because people can remember it. My son also has eosinophilic esophagitis, which goes along with food allergies. And it's just called EOE now. And you see EOE everywhere because so many kids are developing it and adults. But it's this big, huge, long name that no one can even read or spell. Right. And people ask me like, how do you say that? I'm like, well, how do you say Tyrannosaurus Rex? If you hear it enough, it's amazing.
Get used to it like anything else.
Right. You say it, but he's doing great, by the way.
And if you've ever, I'm glad. If you've ever watched a show like ER or Grey's Anatomy or even The Big Bang Theory, you hear terms all the time, then you're like, whoa, do that again? Really? Right.
Mm-hmm. Yeah. And when you hear it for your own family member and become like the expert, it's just, yeah. So I can only imagine all the names of diseases and illnesses that you can just throw out there. Everyone's like, what? Right. Okay. So I don't want to forget something really important, which is I want to read the blurb summary of your next book, which I have not read yet. Okay. Because it sounds really interesting and I want to give it a little bit of time.
Thank you.
So this is not the next in the series, is it? It's a new
No, it's
book.
not a series.
It's a standalone book, okay, which I think is good. Okay, In Good Conscience. And I still don't have my glasses up here, but we're going to. Aidan Sheridan has it all. The devoted partner, the starring role in a TV series, the gorgeous beach house overlooking the Pacific, when he is diagnosed with a life-threatening illness. How is he supposed to face losing all that he has worked so hard to achieve? The worst part isn't the betrayal from his body, but from the people who should have been most fiercely protecting him. He loses the love of his life. His private information is leaked for the world to see, and he must face his mortality, just as all the pieces of his life had been falling into place. Fiona Wood doesn't see it that way. Yes, she interfered with his privacy, but with the greater goal of saving lives. What were her medical ethics compared with that? As she struggles with the inner turmoil and disciplinary action from the hospital where she works, she forges a delicate bond with Aidan that ultimately redeems them both. In Good Conscience exposes both the beauty and the ugly underbelly of sibling rivalry, relationships, love, and forgiveness. Following the acclaim of Brooke's Promise, In Good Conscience once again challenges the reader's sense of what is right, ethical, and just. And when I read that, it made me excited about the book because the title, In Good Conscience, seems like it's playing off of all the ethical dilemmas and people maybe going against something because they're going with their conscience. And it just seems like a lot. So is there anything you want to share about the title or book that you would want readers to know?
Yeah. Well, it's one, In Good Conscience is one of those phrases that I guess I heard a lot growing up.
Mm-hmm.
And so there are a few points in the book where I had written, how can you in good conscience do blah, blah, blah.
True.
And I thought, ooh, naming a book is really hard.
It is hard.
And I can tell you in a minute how I named Brooke's Promise, but with this, it just kind of fell out at me. And I emailed my sister immediately, who read every chapter as I wrote it and is my biggest cheerleader in the world.
Yay.
I said, what do you think of this title? She said, I love it. Don't change it. Done.
That's perfect.
Yeah. Of course, when I told her that I think of this book as a story of the dichotomy between confidentiality and duty to warn, her response was, see, I just thought it was about this poor actor dude who got cancer.
She didn't read into that at all.
That too. That's the vehicle for expressing the whole conundrum. But and Brooke's Promise, I had a lot of trouble naming. I couldn't figure out what to do with it. And I think it may have also been my sister who helped me with this is, well, if we're going to have a foundation named for her, then let's just give the book the name of the foundation. So I just thought that was kind of cool. And for whatever that reveals for people, oh, well, because people like, I just kept wondering what Brooke's Promise was. I'm like, no.
Yeah.
Make a promise.
When I came across it, when it gets to that point, I love that. So that was exciting because you got to see the name of the book in the story. And that's what.
And I had used all of these online services that, try to help you name your book. So I don't know if you did this, but it's almost like one of these spin the wheel kind of things. So they ask you for your 3 main characters and then 4 or 5 character traits of each of them. And what is the main conflict in the book, whatever. Yeah. And then they just give you like 4 zillion different combinations. And like some of them were sort of okay, but they weren't doing it for me. So it's nicer when it comes up organically like that.
Right. And it just fits. When you say it, this is what it's going to be.
Exactly. How did you name yours?
I'm not really sure how it hit me, but I think it was because it feels like my character was trying to resist her destiny the entire way. And that's not something you can do. And I can't remember I wish I knew who quoted it, but I love the quote, you will meet your destiny on the path you take to avoid it.
Oh, I like that too.
Yeah, and that's why I was thinking, it's a dilemma when you're trying to resist your destiny and you can't, like everything you do. And so that's how I got it. But I had some other titles that almost made it. And one reason is because I was able to incorporate them in the story and I wanted to hide them in there, but it just didn't fit. But once I came up with that, I was like, that's it.
That's it.
You stop telling every person, that's it. Right. In your heart, that is the name.
Yeah, it's true.
Okay, well, I'm looking forward to reading that. I'm going to be.
Thank you. I'm looking forward to hearing what you think of it.
Okay, so this next question is going to be really hard hitting, so I want you to brace yourself for it.
Uh-oh.
Okay. When I saw the title of your book, I saw the name Brooke, and my main character's name is Brooke.
Wow.
So, I used that name because I loved it, and it was our girl name. We were going to have a Brooke Elizabeth until it turned out we had a boy, and so we used a different name, and we never got to use it. So I was curious if you liked the name Brooke and wanted it for a child and didn't use it, and now it went into a book.
I did. So our first 2 children are named for people that passed away young and or maybe not young, but had passed away, and we were honoring.
Yeah.
And so their names were not predestined, but the initials that we were using were. But when we were pregnant with the 3rd one, and this was the only one where we did find out the sex of the baby too. We're like, okay, we know it's a girl. What are the girls' names that we liked? And I've always loved the name Brooke. The name was a character in a show that I loved growing up and for years and years. And so I thought that would be wonderful. But with the last name starting with a B, my husband just thought it was too alliterative. He just wasn't really having it. But it was still in the back of my head as something that I really loved. So
yeah, and you were able to use it.
I
I felt really good about using it. Like, finally, I named someone Brooke. I knew I could do it.
Someone I really care about. Yeah.
It wasn't a pet. That would have been fun too, but I could have done that. People do that.
You still can.
Well, I mean, I've really had a great time talking and learning so much. Thank you so much for being here. And I hope you'll come back and do another interview about In Good Conscience.
I would love to.
I would love to talk about it more. So thank you so much.
Thank you. Yeah, this was really fun. Thank you so much for your hospitality. I really appreciate it.
Yeah, this is great. For me, my thoughts, the only way that we can keep learning and growing is to keep asking questions. And that's what I'm going to do with every guest that I have. People love to quote Francis Bacon. I do it when he said, knowledge is power. And it is, but I also love to quote Thomas Jefferson, who said, knowledge is safety, which means something to me. I believe it, and especially with food allergies. So we're just going to keep learning and finding knowledge and sharing information, and we'll do it together. But thank you for watching. I'm Caroline Fleur, and we'll see you next time.